Again, thank you all so much for joining us for today's webinar. Before we get started, I do want to highlight a couple of other upcoming webinars that we're going to be having later this month and also later this year. Next Tuesday, November 10th, will be Biomonitoring and Risk Assessment, Essential Concepts in Emerging Technology with Dr. John F. Reichart at the University of Cincinnati Education and Research Center. Also later this month, on Wednesday, November 18th, will be Jeffrey Hoyle, MS, CPE, presenting on Emerging Technologies, the Future of Ergonomics. And that will be on behalf of the North Carolina Occupational Safety and Health Education and Research Center. Our regular first Wednesday of the month COEH webinar series will be continuing for November and December. On Wednesday, November 4th, we will have Historical Redlining and Health Outcomes with Anthony Nardone, MS, a fourth-year student in the UC Berkeley, UC San Francisco Joint Medical Program. And also on Wednesday, December 2nd, we'll have Dr. Ellen Eisen presenting on job loss, suicide, and overdose. We hope that you can join us for those presentations as well as today's presentation. You can learn about these events and more at our website, coeh.berkeley.edu/about-CE. Now, on behalf of the Occupational and Environmental Health Center, I would like to welcome you to our webinar today on dermatotoxicology, addressing common occupational skin conditions with Dr. Howard Maibach. A few housekeeping items first. You'll be muted during this presentation. If you'd like to ask a question, please enter it into the online Q&A box. We'll save time at the end of the presentation to address as many questions as possible. This presentation is being recorded and will be made available on the Center for Occupational and Environmental Health YouTube page and on our website, coeh.berkeley.edu. All participants who logged in with their registration email will receive an email tomorrow with a link to the recording and an evaluation form that will qualify participants for a certificate of completion worth 1 continuing education contact hour. At this time, it's my pleasure to introduce our presenter. Dr. Howard Maibach is a dermatologist and professor at the University of San Francisco School of Medicine with expertise in treating contact dermatitis, which is a rash by touching an irritating substance, and occupational dermatitis, a rash resulting from workplace exposure to an irritating substance. His specialties include allergic skin disorders and skin conditions caused by exposure to toxic substances. He also has an interest in dermapharmacology, the study of medications for skin disorders. Dr. Maibach earned his medical degree from Tulane University School of Medicine. He completed a residency as well as a fellowship in dermatology at the Hospital of the University of Pennsylvania. Dr. Maibach has served on the editorial boards of more than 30 scientific journals and is a member of 19 professional societies, including the American Academy of Dermatology, San Francisco Dermatological Society, and International Commission on Occupational Health. Thank you so much for joining us today. We're looking forward to your presentation.
Welcome, everybody. You are now social and electronically distancing to the University of California Medical School Occupational Medicine Clinic. It's been operating for a little bit over a half a century, and we've learned a great deal during this time. I wish you could meet all of my colleagues who've helped develop this field, but they wouldn't fit in the room. The field is developing using evidence-based approaches worldwide. So if you would like to put your arms around the knowledge, I can recommend one book to you. I am hopefully showing it now. It is called Canerva's Occupational Dermatology. Not a very exciting title, but it does give you entry into something new and innovative in medicine. Namely, the book is available, of course, in print and electronically. But what is unusual about it, there is a new software system that allows the authors to update every day if they wish to update, not the print copy, but the electronic copy. And of course, the print copy can be done print on demand a few weeks later. So with this book, you can, with a few keystrokes on your computer, you can reach people in much of the industrial world to help you with any special problem that you have. The goal this morning is straightforward. We would like to demystify for you, to simplify for you, to bring it down to patient level, how you can efficiently get to the cause and treat occupational skin disease, but equally important, how you can prevent it. That is the part of the title, Dermatotoxicology. Dermatotoxicology has been an integral part of the development of the field of occupational dermatology. We're going to go quickly, respective of your time, through some of the key issues. The details are readily available to you in the literature, which is very efficiently summarized for you. The first of the key issues in industry is acute irritant dermatitis. This is something that all of you learned probably in 7th, 8th grade or high school chemistry. You were taught not to put sulfuric acid or hydrochloric acid on your skin because you would get, at that time, and still widely used the terminology, acute chemical burn. But of course, it is not a thermal, it's a chemical burn. And really, the simplest nomenclature for it is acute irritant dermatitis. Most of the people in industry who regularly go into factories where chemicals are being utilized already know which of the chemicals need extra precaution. They also know that modern engineering has and should continue to decrease the frequency of it. The clinical diagnosis is obvious. The worker will tell you that they spilled something on their skin, as little as one drop. They know something has happened. They will also often get subjective symptoms, burning, stinging, discomfort. The treatment is very simple. It's avoidance. But if it does happen, I will be talking later about what has been learned in recent years about removing the chemicals from the skin. So in order to be timely, this particular book summarizes acute irritation. Not only does it summarize the clinical aspects, but it goes into the chemistry, which makes it relatively easy to understand and is a basic introduction to something we'll talk more about later, namely decontamination. But irritant dermatitis is a complex syndrome. How do I know it's complex? Well, just simply take a look at this book, which I am calling Shoe Irritant Dermatitis. It's rather thick. In Shoe, you will find that there are many endotypes, many phenotypes of irritancy. But the one that I will emphasize this morning is really the one that is the most common in any industry dealing with irritant chemicals. I am now talking about solvents, we're talking about detergents, we're talking about hydrocarbons. There are some industries where literally in a shop, almost 100% of the workers will have cumulative irritant and chronic dermatitis. Where does the word cumulative come from? Well, it comes from the fact that the first few days, the first few weeks, maybe the first few years, they can tolerate the chemical. Then all of a sudden, they develop dermatitis, most typically on their hands. And then all of a sudden, because if there's a delay in onset of the rash with the chemical exposure, our lab, our clinic, and most dermatologists would instantly say, well, you've been dealing with this for the longest time. It must be allergic contact dermatitis. But in reality, in the field of occupational dermatology, the overwhelming number of chronic dermatitis cases, whether it develops in 2 weeks or 2 years or 10 years, is cumulative dermatitis. We will talk later about how to separate this from allergic contact dermatitis. Now, there is one other form, and it was identified in occupational medicine, of irritant dermatitis that's worth thinking about just for 1 second. If several workers in a plant come up with a photo-exposed distribution, namely their face, their neck, the V of the neck, the hands, etc., that may be, in fact, something called photoirritation. The German word is frequently used as translated into phototoxicity, but it is simply a form of irritant dermatitis which is brought out by exposure to ultraviolet light A. That's the long wavelength form of light that your sunscreen advocates have been talking about in recent years. If the patient is in a cave, they will not get it. The identification of photoirritants, there are not hundreds of them. They're well documented in the literature, and this is where dermatotoxicology comes in. You just simply need an inventory of the chemicals that are being worked with in the plant, and then you can see, has it been reported before as a photoirritant? The treatment is simply to decrease exposure to that, either to the chemical or to the chemical and ultraviolet light A. So that is a very short summary of the common aspects of industrial or occupational irritation. The Chu book goes into enormous detail, and the Canerva Occupational Dermatology book brings you up to date, literally. If the author brings it up to date today, you will have it in the electronic copy. The most commonly discussed occupational dermatosis is allergic contact dermatitis, but we want to emphasize that that is because of social mores and legal liability, especially in Western countries like the United States. It is not the most common form of dermatitis by any means, but it's something that the public is interested in, the law courts are interested in, and so therefore there is a disproportionate amount of information about that in the public press, in the legal press, and in general medical discussion. It is enormously common, namely 50% of the people living in the state of California are believed to be allergic to the pentadecacatechol in poison oak, closely related to poison ivy, closely related to poison sumac, and a few other plants. That's a lot. It is a continuing problem in outdoor workers in places in the country like California where there is a lot of poison oak. The allergen is well identified. The key approach to it is to try to minimize exposure. If there's interest in the question period, we can go into the treatment when it does happen, but avoidance is primal. Now, part of the knowledge of contemporary allergic contact dermatitis in all of medicine came from a boost. The boost came from occupational medicine. The professor of occupational medicine pre-World War II in Denmark suggested that history alone, history is helpful of exposure, but history alone is not enough. He suggested that many allergens in the occupational setting, and now we know in the personal care setting, are not readily identified by either the patient, the worker, or the attending medical staff. So Paul Bonnevie, in a thesis published in German, I have the only copy in the United States if you'd like to share it, and published during World War II, suggested that if you tested every mysterious occupational eruption with some common chemicals in industry, you would save the worker and the healthcare system a lot of trouble. This is known as the baseline series. When we started the contact dermatitis and occupational dermatology clinic at UCSF decades ago, the baseline series was 24 chemicals. We've learned a great deal since then. It is now approximately 70 chemicals. Now, once you know your industry, you quickly learn what are the common allergens in it. Namely, is it due to a glue? If it's due to a glue or an adhesive, you generally know which adhesives it is. There again, the knowledge of dermatotoxicology and preventive medicine is key to preventing disease. And it's industry specific. It is not generic. Namely, a shop that deals with hydrocarbons is different than a shop that deals with adhesives. So, key to clarifying it until you do know the problems in the given factory is something known as diagnostic patch testing. The idea that all chemical rashes are not the same in terms of mechanism was delineated in the venereal disease clinic, not occupational medicine, in about 1898 by a sophisticated observer, the late Yadison. He developed first stage, which is continuing to evolve today, diagnostic patch testing and diagnostic photo patch testing. So this little book that you see here in many editions, this is the recently released 4th edition, in 100 pages roughly, online or in print, gives you the details of diagnostic patch testing and photo patch testing and prick testing, which we'll talk about in a few minutes. The test is readily, easily done. It is not invasive, but the problem is it is a technically challenging assay. So you need to deal with somebody that has experience, not necessarily with some other factory's chemicals, but with the chemicals in your plant or any industry that you're working with. Now, how do you find somebody with some degree of experience in diagnostic patch testing, photo patch testing, and then later prick testing? Well, one hint, you can call me. You've seen in the original screen my email number. You've seen my cell phone number. But also, there is a society slowly growing in the United States. It has about 900 members called the American Contact Dermatitis Society. They have a website. They have a listing of members where they're located, and then you can email them to see, do they have the interest of dealing with occupational allergens? This is time consuming and it is not for everybody, but there are enough to go around that they should be able to help you with a given problem. We want to emphasize 2 points about it. One, you need the occupational allergens in the refrigerator, or you need the ability to get them from the work site if they're not commercially available and have them diluted. Second, you need a healthcare worker that understands the technology, false positives, false negatives, and all of the 100 pages, but most importantly, clinical significance. Many normal people are patch test positive to many chemicals. I have sensitized myself by mistake to numbers of chemicals. I continue to be exposed to them, but I keep the level of exposure below what is clinically obnoxious. So again, you want to deal with somebody with a special interest in occupational dermatoses. The second part of allergic contact dermatitis we will deal with even more briefly. It is called photoallergic contact dermatitis, and it was originally picked up by a shrewd dermatologist, the late Darrell Wilkinson, in a soap factory, Unilever, in the United Kingdom. What he saw was a group of workers who were making bars of soap, but then seemed to develop a photoexposed dermatitis. That is photoallergic contact dermatitis. The diagnostic aid is called photo patch testing. And again, there is a scattering of people in North America that can do this for you in the unlikely case, but it could happen, that you found a new photoallergen. The list of chemicals that are known to produce photoallergy are succinctly described in the International Contact Dermatitis Research Group book, which I'll refer to by my senior editor, Jean-Marie Lachapelle. This is rare, but it's important because a small subset of those individuals develop a devastating clinical syndrome known as persistent light reaction. They stop using the chemical, but every time they get even minutes of sunshine exposure, their whole body may develop dermatitis. So it's a very serious event. And again, here dermatotoxicology is critical. We want to avoid exposure to these chemicals in industry and in personal care as much as we can. So now you've heard about the complexities of the irritant dermatitis syndrome, mainly acute irritation and cumulative irritation. And you have one simple reference to that broad syndrome. You've heard about allergic and photoallergic contact dermatitis, and you have one very short reference online or in hard copy where you can learn the details of mechanisms and a great deal that has been learned in the century since Yadison first brought it to our attention. The next syndrome that we'll deal with is the syndrome of contact urticaria. We would expect that most of you listening to this short dialogue today may never have heard the term, but you're probably familiar with the idea because many of you might have been around 10 years ago in the healthcare industry and knew about latex protein. You knew about people who dealt with latex gloves and developed anaphylaxis. You also may know of some deaths. So what is the contact urticaria syndrome, and what is a simple reference to it? Well, there are several editions of knowledge of this. The most recent is the only one that I'm going to bring to your attention. My senior editor here is Ana Jimenez Arnaud in Spain, Contact Urticaria Syndrome, Springer. It consists of two disparate mechanisms. Mechanism one is a little bit annoying, easily dealt with, and not a significant medical problem. Some of you who are athletes and who use the internet widely advised dimethyl sulfoxide may know about that one. It is NICU, non-immunologic contact urticaria. Those of you who are hikers, if you wear short pants and short socks, the rash that you get around your ankles when you get exposed to nettles, the nettle rash, that is non-immunologic contact urticaria. It does not elicit systemic symptoms. It has not killed anyone. It doesn't cause chronic disability. You can put two and two together. The contact urticaria book lists those chemicals that are known to do it. Now, and it's really a dermatotoxicologic issue. Let's figure these chemicals out, then minimize the exposure. But more important, medically and health-wise, is the ICU, immunologic contact urticaria. This is the syndrome in which individuals can handle the chemical like a latex glove without any difficulty at first. They have to develop an immunologic response. Now, we didn't mention for allergic contact dermatitis and photoallergic contact dermatitis, the message is on the white blood cell, and it's called delayed hypersensitivity. So if you read about diagnostic patch testing, we put the allergens on day 1 and look for a response at day 3, 5, and maybe 7. For contact urticaria, the message is a protein, immunoglobulin E. How do we know that? Well, the first patient that we ever saw, a patient that was misdiagnosed by my colleagues at Stanford and myself, unfortunately, has an immediate response to the common insect repellent diethyltoluamide or DEET. When we diagnostically patch tested her, because we were told by the internist at Stanford that she was allergic to DEET, we only knew about delayed sensitivity, so we put the insect repellents on day 1, and day 5 it was negative. The patient then, when we told her this information, looked me in the eye and said, "Doctor, you don't know what you're doing." And of course, now and then, I bloody well know lots of times we don't know what we're doing. She said, when I get exposed to the insect repellent, I get a rash not in days, but in minutes. That is contact urticaria. In her case, to show that it was probably a protein, we don't do it anymore, took some of her serum, injected it into my skin, namely known as passive transfer, and I, for a day or so, reacted to DEET. It occurs in several stages. If the patient, the occupational worker, is fortunate, they'll only get skin symptoms. But as their level of sensitivity increases, they then may get allergic rhinitis, runny nose, allergic conjunctivitis, runny eyes, asthma, shortness of breath, anaphylaxis, and in the worst case, death. So immunologic contact urticaria is highly important. Most of the chemicals that cause it are low molecular weight chemicals, and many, after we mistakenly published the original papers on the contact urticaria syndrome, thinking it was rare, we now know it is not rare. You will see in the Jimenez Arnaud book online or in print the numbers of chemicals that produce it. The overwhelming majority have been identified clearly in industry. So again, in an industry-specific manner, all you need to know is the basic dermatotoxicology. You look at the chemicals, do these ever produce immunologic contact urticaria? And there is a sub-variety of immunologic contact urticaria, which could confuse you, could confuse your dermatologist, could confuse your allergist, because a small subset with a relatively small number of chemicals, and we'll go into the chemistry in a moment, evolve over chronic exposure that didn't lead to anaphylaxis. The worker or the person continued to use the chemical. They switch from urticaria or hives, acute, to instead they get eczema. They get dermatitis like irritant dermatitis and allergic contact dermatitis. Until this syndrome was defined some 25 years ago, these workers were thought to have either atopic dermatitis or chronic irritant dermatitis or allergic contact dermatitis. But the key to picking these people, these workers up, is to ask a very simple question. Have any of your staff ask, is there anything that you touch that produces burn, sting, and itch within minutes to an hour or so? If it does, then you should suspect either non-immunologic or immunologic contact urticaria. The testing for immunologic contact urticaria can be done in one of two ways. If you're in a country or in a place where the allergists and the dermatologists have experience with this, the quickest way is simply a prick test. But generally, before a prick test is done, or the alternative, which we'll go into in a moment, one separates out the patients that get systemic symptoms from those who do not. Those that do not get anaphylaxis, clearly you can go right to the prick test. Those that do get systemic symptoms, the prick test allergen might be diluted, or you might do something even more straightforward and simpler, and that is diluting the chemical to maybe 1 to 1,000,000, 1 drop. If it's negative, a half hour later, 1 to 100,000, 1 to 10,000, etc. All of the details of this are covered in the contact urticaria simple summary that I mentioned before. But please remember that there is this subvariety. It is almost always occupational. It is most typically with proteins, so it's often called protein dermatitis, but it is IgE and not delayed sensitivity, and it is tested for in a different way. It is immediate testing, not delayed testing. Now, the next module after contact urticaria is something that all of you, or almost all of you, are enormously experienced with. It is removing chemicals from the skin, or not only in the workplace, but if you happen to be anywhere where the Russian government is involved, you're well aware of the number of instances in recent years where very potent chemical warfare agents have been put on unsuspecting individuals, either on their face, in the case of Korea, put on by young women in an airport, or on doorknobs if you happen to be somebody that the Russian government wants to get rid of in London. How do you get chemicals off the skin? Well, all of you know, you look at the material safety data sheet. It is of use. It does give you some chemical identification. It does give you the name of a supplier, an email, and a telephone number. If there is a generic listing on it, 99.2% or maybe 99.9% of the time, it recommends washing it off with water or soap and water. And that is still reasonable guidance. But in recent years, partially due to the need to deal with chemical warfare agents, and we know about our invasions in the Middle East about chemical warfare agents, and Colin Powell, our Secretary of State. Because of that, we've learned significantly about the mechanisms of how to get chemicals off the skin. Obviously, in this demystifying brief overview of tools at your disposal, the simple reference that I can give you is a book, not with a surprising title, Decontamination. And my senior editor here is Dr. Zhu, who's now working in China. And basically, what the new information suggests is as follows. Point number one, probably the most important point. If you're dealing in an occupational setting with a chemical that gets into the body and can be acutely toxic, like an organophosphorus agent, there is good information summarized in Zhu's book that when you wash it, you acutely can increase the dose that gets into the body. So you can take something that is moderately toxic and make it acutely toxic. For that and many other reasons, there are alternatives that are being developed for decontaminating the skin, decreasing the amount that gets into the body. In a few minutes, we will talk about sunscreens and many other chemicals with potential for chronic toxicity and what we know and don't know about that. But if you're dealing with acutely toxic chemicals in any of your workplaces, you probably want to learn what is known about the ability to get that chemical off the skin, and is water and soap and water the most rewarding and efficient way to do it? Or are there alternatives? Or should you authorize the development of alternatives for which there is some experience? So that is the decontamination module, a field that is rapidly and fortunately improving. Now, as a general introduction, I realize that not everybody wants to get a PhD and postdoc in dermatotoxicology. We could use another 100 or so worldwide, maybe 200, where there's a great shortage of at the moment. But a very straightforward, demystifying way of looking at it without a PhD and a postdoc is a little tiny book. This one is called Applied clinical dermatotoxicology. What it does is it tries to demystify how to approach the problem for each individual work site. Unfortunately, I'm the senior editor of this one, authored by mistake. The publisher is Academic Press. So it gives you, in 100 pages roughly, a clinical approach. But for those of you who want to converse with the toxicologists who work in this area, you need a little bit more information. So a simple textbook on the methods of dermatotoxicology, there are really two of them. I'll only show you one of them. The senior editor of both of them was a wonderful, now deceased public servant at the Food and Drug Administration, the late Francis Marzulli. It comes in two flavors. The one that I'm showing you is probably the most simple to start out with. It's a vademecum. It's just a very short approach to dermatologic, toxicologic methods. The full version is about 1,500 pages. It is also called the straight Dermatotoxicology, Marzulli and Maibach, the current edition. And in it, you will learn the methods and much of the knowledge that will allow you then to go from Canerva's occupational dermatology to each individual work site and figure out the potential for damage and how you can prevent it. Now, inherent in dermatotoxicology is something that has been confused in the literature and in medical practice over many decades, but is now in the process of being truly demystified and brought to public attention. And that is percutaneous absorption. When we started at UCSF in the field, it was the general belief that your outer layer of skin, your stratum corneum, kept out almost everything. Now, some decades later, we know the complete opposite. Namely, any chemical under maybe 800 or 900 Daltons is probably getting in the skin of the worker, or you if you use skincare products. So an introduction to the techniques of quantifying percutaneous penetration is found in this little book, again from the Food and Drug Administration. Our senior editor in this is fortunately alive but retired, unfortunately retired, Robert Brunau. The name of the book, unsurprisingly, is Percutaneous Absorption. And it is the current edition is the 4th edition. The 5th edition will be out in about 6 months. Now, what is the relevance of that to you who work with industry? Well, there are two recent observations that have enlightened the general public. I am talking about the Washington Post, the Wall Street Journal, the New York Times, the Guardian. The two pieces of information that have alerted the worker and the general public. The first one concerns what most people would have thought was banal, sunscreens. But for those of you who read your newspapers in February of this year, you saw a document in which my colleagues and your colleagues at the Food and Drug Administration studied percutaneous absorption of sunscreens in vivo in man, something that we initiated decades ago with para-aminobenzoic acid, with me as the first volunteer. Many of them are well absorbed, And if you read the original paper by Matta, you will see we have all too little information. Can the body excrete them? So it's not only absorption, it's excretion. For those of you with training in general pharmacology, you probably know A, D, and B: absorption, distribution, metabolism, and excretion. So it's becoming an important part. The other part that has brought this to the attention to the worker and many other people is the ongoing litigation about, does Roundup, or specifically its active glyphosate, produce malignancy? And maybe if you've been following that complex litigation, but one of the issues is, does the chemical get into the body? So we predict that in the next number of years, percutaneous penetration is like general dermatotoxicology, but will become an enabling tool to help you protect not only yourself, but the worker. So with that, and in behalf of my colleagues worldwide in occupational dermatology who can't be with us today, we thank you for your attention. You do have my email. We try to answer it at 7 in the morning and 7 at night, 7 days a week. And the cell phone number, but the cell phone number does not go on. It is 7 days a week, but it starts at 7 a.m. for any of you who are away from Pacific time. Thank you all for your kind attention.
Thank you so much for your presentation. Really appreciate it. At this time, if you are one of our audience members, you are welcome to use the online Q&A feature. And I'm going to read some of our questions aloud and give Dr. Maibach an opportunity to answer your questions. And also, just as a reminder, we are recording today's webinar. We're going to put this recording as well as the books and recommendations from Dr. Maibach on our website. It's the same page in the link that you registered on. So later this week, those resources will be available there as well. So we do have some questions coming in. The first, someone was asking if you can distinguish the differences between irritants and allergens.
Simply, and this is fundamental to occupational dermatology, an irritant is a non-immunologically related phenomena. The chemical damages the skin, it gets into the skin, the epidermis, the dermis, and when it does that, eventually produces dermatitis. That's straightforward. Allergic contact dermatitis, you're not born with to it. You develop hypersensitivity. So those of you with long experience in the occupational work site notice the frequency increases with age because of increasing exposure. And by the way, there's even a hint in man that the tendency is genetically determined. So the message is carried in the white blood cell. It's delayed in onset, and that's why the key reading after exposure in the diagnostic patch test is 5 to 7 days, where the irritation we know of no immunologic consequence. But because of human biology being as fascinating as is, some chemicals are both irritant and allergic and allergens. Is that responsive to your question?
I think so. And if they have a follow-up question, you're welcome to also ask that in the Q&A. Thank you. We also have another question. Are there any substances out there where only known exposure route is through inhalation and it causes a dermal reaction?
Again, a very shrewd and substantive question. So I will do my best, and then I will refer you to the ultimate source of the knowledge. Traditionally, until the 1970s, it was believed that inhalation clearly was a different toxicologic issue and was not related to the skin. But then a remarkable woman in her PhD program, Merle Carroll, that you'll find the literature under Karol, doing animal studies, showed convincingly, at least to me, that you could produce pulmonary immunologic effects with induction by the skin. Now, over the decades since then, Dr. Carroll eventually retired from her academic position in Pittsburgh. Some clinicians have been alerted to it and are beginning to look at it, both the skin triggering the lung and vice versa. So I would recommend that if anybody wants to go into this, I'd be happy to discuss it with you on the phone. It should be the subject of a number of PhD theses and postdocs, because it is probably clinically important and often missed.
Great, thank you so much. We do have quite a few more questions, so we'll try to get through these as many as we can. What is your best advice for the method to decontaminate skin after hydrofluoric acid exposure? And a follow-up, do you have any opinion of the hexafluorine decontamination product from Prevoir?
Potential conflict of interest. I am a token dermatotoxicologic consultant to Prevoir. I don't own any stock. It's not a substantive part of income, but I would recommend that this is a life and death matter. People are still dying of hydrofluoric acid skin exposure. They often have significant disability, as the person who brought this up. There are several review articles trying to lay out the evidence for each of the interventions, both in terms of decontamination and in terms of electrolyte interventions. The most recent publication is a 2020 review. You'll find, if you punch in my name and the name of Dr. Hall again, you will find our reviews. My judgment is, because this is life-threatening, it deserves even more attention.
Thank you. We have another question about chemical exposures and whether it's possible to absorb chemical exposures from the eyes due to airborne exposures.
Would you repeat the last part of the question?
Yes. Are there chemicals that are absorbed through the eye from airborne exposures?
You will have to refer to an ophthalmologist who's interested in that, but I'll tell you a little bit that I know, and then I'll give a recommendation. We know that you can get systemic toxicity from eye exposure. So that is clear. Number two, we know that in immunologic contact urticaria, the finger can cause the eye to become inflamed from the immunoglobulin E mechanism. Three, a specialist in ophthalmic toxicology of which there are not hundreds in the world, is Norbert, Norbert, Schrage, Schrage. And if you'd like a quick way to learn about what he has been doing for many decades, you can simply go on to the web. He has a website. He has a similar book to our book with Hall on acute ophthalmic toxicology, which I did the editing on, but I'm not in any other way involved. And then lastly, you might check to see, for many years, the Food and Drug Administration in the United States retained the part-time services of an ophthalmologist in Portland, Oregon, who would answer such questions. So I would go to the FDA website to see if that is still operational, to the ophthalmology division.
Excellent, thank you so much. We have a follow-up question on sunscreen. I understand that sunscreen contains nano-sized titanium dioxide. Is this safe for application on baby skin?
Well, we would recommend that the person who asked this question get the full banana, the whole story. First, I would recommend you look at the February Journal American Medical Association, JAMA, for the Mata article on absorption and excretion of sunscreens. Secondly, we have delved in a little bit deeper. I am hoping that on the web will soon be available a paper done with one of my former postdocs in Switzerland, where we dig into this even more deeply. The senior author will be Christian Surber, S-U-R-B-E-R. But the short answer, the so-called skinny, is at the moment, the inorganic sunscreens seem to have the highest safety ratio.
Great, thank you so much for those additional resources. We also have a comment/question. First, I want to say thank you for a very informative presentation. I also wanted to follow up and ask, do you believe that we will reach a time when cell phone cameras combined with AI and libraries of dermatitis photographs might be used for rapid field screening for dermatitis? For example, allowing screening of regions where dermal experts may not be readily available.
This is the most wonderful question because I know the whole answer. In one word, yes. Our work in the occupational dermatology clinic has been revolutionized with the camera. The workers come in and they bring many patients, saving me going to their work site. I still do go to work sites, but it's a great time and great efficiency to the field. Secondly, yes, some problems can be addressed totally with the phone camera. So you're on to the right track. It's a major part of the future.
Great, excellent. See, emerging technology is a theme for our webinars this month. We also have a comment. Your presentation is so aligned with industrial hygiene and occupational health. There are occupational exposures to beryllium, metal, and compounds, formaldehyde, hexavalent chromium, petroleum-based cutting fluids, and others. AIHA would love to share your knowledge with our board-certified colleagues domestically and internationally.
Does that require a response?
I don't believe so, but I wanted to share. Excellent. Well, thank you so much. We are now reaching the end of our presentation. As you can see on the screen, we do have Dr. Maibach's contact information, which you are welcome to copy down for yourselves if you have further follow-up questions. A special thank you to everyone who joined us for today's webinar and to our presenter for being here with us today. Be sure to check out our website for more information. It's coeh.berkeley.edu/about-CE. And as a reminder, we'll be sending out an email tomorrow with the webinar recording and an evaluation link. And that'll be for everyone who logged in with their registration email today. Thank you so much for your wonderful questions and participation. And I hope you have a wonderful rest of the day. Thank you so much.